Hi friends, I'm Dr. Sumana, Professor of Microbiology at JSS Medical College and Hospital, JSS Academy of Higher Education and Research, Mysore. And in today's session, I'll be taking you through some puzzles which help you in the rational use of antimicrobials in the lower respiratory tract infections. Before I take you through the puzzles, just for you to remember that there are bacterial pathogens and viral pathogens mainly causing the lower respiratory tract infections. The most common bacterial pathogens are the escape pathogens, along with Streptococcus pneumoniae, Haemophilus influenza, and Enterococci, of course, which is a part of escape pathogens, and Streptococcus pyogenes. All others are the escape pathogens, and these are the bacteria that cause typical pneumonia. And there are some pathogens which cause atypical pneumonia. They are Chlamydia pneumonia, Legionella pneumophila, Mycoplasma pneumoniae. And amongst the viruses, you have parainfluenza virus, coronavirus, human metapneumovirus, adenovirus, influenza virus, and respiratory syncytial virus. Amongst the typical escape pathogens, I'm just giving you some photographs so that you will have the photographic memory. So these are gram-positive cocci pairs, the commonest cause of lower respiratory infection, that is Streptococcus pneumoniae. Then cocci in clusters, which are staphylococci, and cocci in chains, enterococci are Streptococcus species. And based on the microscopic morphology, you'll be able to remember the etiological agents. And amongst the gram-negative organisms, the mucoid colony forming organisms on McConkey's agar, that is Klebsiella pneumoniae. Then you have the pale pink colonies on McConkey's agar Acinetobacter. Then you have the green colored pigment producing organism, that is Pseudomonas. Then you have the lactose fermenting colonies, either Enterobacter or Escherichia coli. So this photographs will help you to remember at least the important etiological agents. So what we must remember is both gram-positive and gram-negative organisms are responsible for causing this bacterial infections of the lower respiratory tract. Now, amongst the atypical pathogens, we have Chlamydia pneumophila. A refers to atypical pneumonia. L refers to Legionella pneumophila. M refers to Mycoplasma pneumoniae. I just call this CALM because the symptoms caused by these atypical pathogens are usually quite silent. Like it's also called as walking pneumonia. The patient may not have very marked symptoms, but that doesn't mean that these infections cannot cause morbidity and mortality. So we need to also try to keep in mind that these pathogens can also cause infection and they need to be treated promptly. Now, before I take you through the puzzles, first and foremost, what I would like to tell you is the major differences between the bacterial infections and the viral infections. So if you understand the basic principles of how the bacterial infections present and how the viral infections present, you will be able to differentiate between the bacterial and viral infections. So if they happen to be viral infections, you don't need to give them any antibiotics. So antibiotic preserving is very important. Saving them for future is very important. So now let us try to understand how the bacterial infections present and viral infections present. So these are some of the general features. So based on this, your puzzles will be designed. So understand these basic principles and then try to solve the puzzle. Now, coming to the onset, in the bacterial infection, it is sudden, while in the viral infections, it's insidious. That's why prodrome is absent in bacterial infection, while prodrome is present in viral infections. And fever is usually of a higher degree, that is 102 degree Fahrenheit or 39 degrees Celsius in bacterial, and it is less pronounced in viral infection, less than 102 degree Fahrenheit or 39 degree Celsius. And inflammation, if you consider, which is a response of our body towards any kind of injury or any infection. So the inflammation in bacterial infection is severe, but it is more localized. While in viral infection, it is less pronounced, but more diffuse. And the secretions, that's why in bacterial infections are purulent, while in viral infections, they're watery. Myalgia may or may not be present in bacterial infections, but in viral infection, it's a marked feature. Coming to the leukocyte count, there can be leukocytosis or leukopenia, especially in gram-negative infections. And there is leukocytosis in bacterial infections. Coming to the differential count, there is neutrophilia in bacterial infections and lymphocytosis in viral infection. Now, cough, if present in the bacterial infection, is productive right from the beginning with purulent sputum, while in viral infection, initially it is dry and later becomes productive with white sputum. Now, coming to C-reactive protein, which is a marker of inflammation. So, we know that there is severe inflammation. So, CRP is raised to a greater extent, that's more than 80 milligram per liter or so. While in viral infection, it is less pronounced. So, the CRP is around 20 milligrams per liter. Now, procalcitonin, which is a marker of bacterial infection, is more than 1 milligram per liter in bacterial infection and less than 1 milligram per liter in viral infections. Now, taking the chest X-ray, there will be one white condensed area of opacity with other areas of the lung visualized as having normal air exchange in bacterial infections. But in viral infection, you have ground glass homogeneous opacity all over the lung field. But this kind of a picture may be seen even in atypical pneumonia caused by bacteria, for which it's a different kind of treatment strategy, which we shall discuss a little later. Now, based on these general features that I just now described on the bacterial infections and the viral infections, what you need to do is you need to differentiate the host of features that I give you in the next slide into viral etiology where no antibiotics are required or bacterial etiology where antibiotics are required. So you'll have balls written with the symptoms on each of the ball. So you have to push the ball into either this basket which are features of viral etiology where no antibiotics are required, or into this basket which are the features of bacterial infection where antibiotics are required. Now we will take up this particular feature now. So what you need to do is once you push each feature into either bacterial or viral basket, you need to multiply the order number of each feature by 5 into this basket called Panchali. And for viral infection, you need to multiply with 10 and push it into this particular basket called Dashavatar. Now, I'll give you a host of features here. Myalgia plus or minus, that's order number 1. Number 2, myalgia plus plus. Number 3, insidious onset. Number 4, fever plus or minus. Number 5, cough non-productive initially. Number 6, fever of high grade. Number 7, acute onset. Number 8, prodrome of congestion and cough present. Number 9, breathlessness plus with pleuritic pain. Number 10, breath sounds may be reduced all over the chest area. Number 11, breathlessness present but without pleuritic pain. Number 12, cough productive from the beginning and with purulent sputum. Then number 13, prodrome of congestion and cough absent. Number 14, breath sounds, unilateral reduction of breath sounds and normal vesicular breath sounds on all other areas of the lung. Now you need to differentiate these features. Now number 1, myalgia plus or minus, which is a feature of bacterial infection. High-grade fever is a feature of bacterial infection. Acute onset again is a feature of bacterial infection. Breathlessness plus with pleuritic pain, because the inflammation is severe, there is pleuritic pain. So this is a feature of bacterial infection. Then number 12, cough productive from the beginning, and there is formation of purulent sputum. So prodrome of congestion and cough absent. So there is no prodrome in the bacterial features or bacterial infections. And number 14, breath sounds, unilateral reduction of breath sounds and normal vesicular breath sounds in other areas. Again, a feature of bacterial infection. So order number is 5. Sorry, order number multiplied by 5. So if you total up everything, you'll get 310. Now, in viral etiology, myalgia plus, you know it's a feature of viral etiology. Then insidious onset again is a feature of viral etiology. Then fever plus or minus again is a feature of viral etiology. Number 5, cough non-productive initially. Then number 8, prodrome of congestion and cough present. Number 10, breath sounds may be reduced all over the chest area. Number 11, breathlessness plus but without pleuritic pain. So the order number is multiplied by 10. So all these features together go to Dashavatar. So it will be 20 plus 30 will be 50. This plus 40 will be 90. 90 plus 50 will be 140. 140 plus 80 will be 220. 220 plus 100 will be 320. 320 plus 110 will be 430. So in Dashavatar you should get 430. If you rightly place the features either into the basket of bacterial etiology or viral etiology, you should be getting the correct total as shown here. Now similarly, we have to look at the lab parameters. So sometimes just the clinical features may not be helpful for you to differentiate between bacterial and viral etiology. With some laboratory investigations, it may help you to differentiate between the viral and bacterial etiological agents. Now these are the features. Again, the rules are the same. Whatever is the feature of bacterial etiology, it will go into the basket called Panchali. The order number gets multiplied by 5. While if it is a feature of viral etiology, it gets pushed into Dashavatar basket. So the order number gets multiplied by 10. So what are these features? Let us see. Total count, leukocytosis. Number 2, differential count, more of lymphocytes. Then C-reactive protein of more than 80 milligram per liter. Procalcitonin less than 1 milligram per liter. Or procalcitonin more than 1 milligram per liter. Then number 6, chest X-ray ground glass homogeneous opacity of the lungs. 7, chest X-ray one wide condensed area of opacity with other areas of the lung visualized as having normal air exchange. Number 8, total count either leukocytosis or leukopenia. Then differential count more of neutrophils. CRP of around 20 milligram per liter. Now we need to understand this now. So number 1, CRP of more than 80 milligram per liter obviously is a feature of bacterial etiology because the inflammation is severe. Procalcitonin of more than 1 milligram per liter, again feature of bacterial etiology. Number 7, chest X-ray, one wide condensed area of opacity with other areas of the lung visualized as having normal air exchange. Then number 9, differential count more of neutrophils. So the total will come to 210. We'll see what goes into this basket called Dashavatar. Number 1, total count leukocytosis. Then differential count more of lymphocytes. That's number 2. Then number 4, procalcitonin less than 1 milligram per liter. Then number 6, chest x-ray, ground glass homogeneous opacity of the lung. Then CRP of more than 20 milligram per liter. So all the order numbers get multiplied by 10 and total should come to, let us see, 1 plus 2, 3, 3 plus 4, 7, 7 plus 6, 13 and 13 plus 10, 23. So the total should be 230. That gets multiplied by 10. So this is how we try to differentiate between the bacterial infections and viral infections. Not a single feature at a time should be considered. All the features together should be considered and then decide as to whether this particular infection that you're dealing with is of bacterial etiology or viral etiology. At least in 50% of the cases, if you can avoid the use of antibiotics for viral infections, we are preventing the antimicrobial resistance. So this is one step forward in preventing antimicrobial resistance and doing the correct antimicrobial stewardship activity. Now, what we should be doing is to understand the various antibiotics useful in the treatment of lower respiratory tract infections. Here I have given you a host of antibiotics. For example, amoxiclav used at 625 mg orally 2 or 3 times a day, or it can be IV 1.2 grams 3 times a day. Then cefuroxime 750 mg 3 times a day. Then cefpodoxime 200 mg twice daily. Ceftriaxone 2 grams once daily. Cefatoxime 1 gram 3 times a day. Piperacillin tazobactam 4.5 gram 3 times a day for mild to moderate infections and 4 times a day for severe infections. Imipenem 500 milligram to 1 gram 3 to 4 times per day. Meropenem 1 gram 3 times a day. So now what you need to do is, I have given you the dosage and the number of times per day that you need to use. Here, using the numbers 0, 1, 2, 3, 4 and 5 only, you must fill the table. I have given you the dosage. So by doing this number puzzle, what you will understand is, whatever antimicrobial we use, they shall be used in appropriate dose for appropriate number of times and for appropriate duration. Here I have not mentioned the duration because most of these are injectable antibiotics. You start the patient on injectable antibiotics. The same injectable antibiotic need not be given for a longer duration. Based on the culture and sensitivity report, if the organism happens to be sensitive to a lower antibiotic or an oral antibiotic, you may change over and the total duration of treatment varies. See, for most of the lower respiratory infections, we give a minimum of 7 to 10 days of treatment. So altogether, the injectable and the oral formulation that we give together should come up to 7 or 10 days depending upon the severity of the infection. Now let us see how we solve this puzzle. Now, this is the table. What we need to do is, we need to write these numbers using only numbers 0, 1, 2, 3, 4 and 5. Now, how do we represent this 625? We represent it as 500 plus 125. These are very simple mathematical puzzles. Just for you to remember, appropriate dose for appropriate duration is very important. And then here 1.2, you don't have to change anything. 3 or 2 times a day. Of course, oral is given 3 times a day. Injectable either 2 or 3 times a day, and duration is say 10 days. Now cefuroxime, which is a second generation cephalosporin. It's given at a dose of 750 milligram. Let us see how we represent 750. Very simple. 750 will be 500 plus 250 given 3 times a day. Cefpodoxime 200 mg 2 times, there is no need to change. Again ceftriaxone 2 gram once, no need to change anything. Cefatoxime again 1 gram 3 times, no need to change. Piperacillin tazobactam 4.5 grams 3 times a day for mild to moderate infections and 4 times a day for severe infections. Imipenem 1 gram or 500 mg, here also you don't need to change anything, 3 or 4 times a day. Meropenem 1 gram 3 times a day. Say again, duration I have not mentioned because you may change the IV formulation into oral formulation based on the culture and sensitivity report. Now 10 days can be represented as 5 into 2 here. So by using only numbers 1, 2, 3, 4 and 5 plus 0, you need to represent the various doses of the antibiotics to be given, the number of times per day and the duration. Now, one more thing I would like to tell you as a pearl of wisdom is you have to always treat any bacterial LRTI, especially community acquired LRTI, with double antibiotics. Why? You need to cover the typical pathogens by using beta-lactam antibiotics, while the atypical pathogens are usually covered using doxycycline or macrolides. So now, by solving this particular puzzle, so these are or a set of antibiotics or 2 antibiotic combinations which will be helpful in treating the lower respiratory tract infections, especially community acquired LRTIs. Now to solve this particular puzzle, what you need to do is, in the next slide I have shown, let me show you the next slide. Now here we have beta-lactam antibiotic which is to be given to cover the typical pathogens. Which beta-lactam antibiotic? Again, based on the severity, we will discuss what antibiotic is to be given. Now, to cover the atypical pathogens, I have given you a host of options here. Tigecycline, colistin, aminoglycosides, fluoroquinolones, macrolide, and doxycycline. Now, how to solve this puzzle? Now, if you join this line AB with CD, there are many CD lines. So each of this A, B, C forms different angles. Now the correct answer will have 147 as the angle and one more angle is 165. Like the one which forms this 147 will be macrolide and the one which forms 165 will be doxycycline. So macrolide and doxycycline is the answer for this puzzle. So if you bring this protractor, I have provided a protractor. If you bring this protractor onto this angle to measure ABC, the angle that measures 147 is macrolide. So you use the macrolide, or the angle that measures 165 corresponds to doxycycline. So use either a macrolide or a doxycycline to cover the atypical pathogens. So you have to always use 2 antimicrobials to cover the pathogens causing bacterial infections of the lower respiratory tract, especially of the community acquired origin. So 147 is macrolide and the angle 165 corresponds to doxycycline. So that's how you're going to solve the puzzle. So I call this as death by double strike. So you're striking the organisms with 2 antibiotics. So I call it as death by double strike. Now, what are the options of treatment of pneumonia? Again, Based on the severity, our Indian Council of Medical Research 2022 guidelines have given the following antibiotics. If you're treating pneumonia or LRTI on the OPD basis, you use cefuroxime, second generation cephalosporin, and then cefpodoxime, a third generation oral cephalosporin, and then amoxiclav, which can be an oral formulation or an IV formulation. So on OPD basis, you may want to give it as oral formulation. And if you have admitted the patient in the ward, so the less severe ones you will be admitting in the ward, and the more severe ones you will be keeping them in the ICU. So IP ward, what is the recommendation? Amoxiclav or ceftriaxone and cefatoxime, one of the three. Now, if you've admitted the patient in ICU, the guideline says ceftriaxone or cefatoxime or piperacillin tazobactam, which is a beta-lactamase inhibitor combination, which appears to be more potent than the third generation and the fourth generation cephalosporins. Now, if you have admitted the patient in the inpatient in the ICU with suspected multi-drug resistant organism, especially patients who have been admitted in the hospital for a long time or who have been given multiple antibiotics for a long time, in such situations, you suspect multi-drug resistant organisms. In such a situation, ICMR advises you to use piperacillin tazobactam or imipenem or meropenem. Now, you just keep this in mind. Now, I have a challenge for you. Here is another puzzle. Now, I have given you the host of these antibiotics. You have to fit them into this Venn diagram. See, between OPD and IP ward, there is one antibiotic that is common, which I have already explained to you. And between IP ward and IP ICU, there is one antibiotic which is common, which needs to be represented here. And similarly, between IP ICU and suspected MDRO, there are some common antibiotics which need to be represented here. So how do you solve this puzzle? I call this as where in when puzzle. This is a Venn diagram where you need to place these antibiotics. I have given you a host of antibiotics as advocated by the latest ICMR guideline. You need to place them appropriately in this Venn diagram. So how do we do it? Let us see. So cefuroxime and cefpodoxime used on OPD basis, the oral formulations. So you place it there. Amoxiclav may be available as an oral formulation or may be given as the IV injection form. So this is one common antibiotic between OPD and IP ward. So we place amoxiclav here. Now the other one which is recommended is ceftriaxone or cefatoxime. And these antibiotics are common for ICU also. So ceftriaxone and or cefatoxime is given along with one more option that is recommended is piperacillin tazobactam. So IP ICU you have ceftriaxone or cefatoxime and piperacillin tazobactam. Now IP ICU MDRO, so either piperacillin tazobactam or if you want to go to higher antibiotic, imipenem or meropenem. So this is hierarchy for severity. So based on the severity, so these are the beta-lactam antibiotics. I was telling you we need to target these organisms causing lower respiratory tract infections using one beta-lactam antibiotic, the other one being a macrolide or doxycycline. So what is the choice of beta-lactam antibiotics? I've tried to simplify the concepts or the guidelines given by ICMR into this simple format of Venn diagram. So OPD, what you need to give, and then IP ward, what is the common antibiotic between OPD and IP ward, and what are the common antibiotics between IP ward and IP ICU, and what are the common antibiotic between IP ICU and IP ICU with suspected MDRO. So like this, it will be easy for you to remember based on the severity what antibiotic, especially what beta-lactam antibiotic is to be chosen for the treatment of lower respiratory tract infections. Now, sometimes you'll have to cover the patient for Staphylococcus aureus. So when do we suspect Staph aureus infection? Because when you have the patient coming in, empirically you may have to think of using some gram-positive cover in the following conditions. Post-influenza, if I give this mnemonic as Pepsi, now this P is replaced by B. So P is post-influenza, E is empyema, if there is empyema thoracis, or if there is bronchiectasis, B refers to bronchiectasis, and then S is structural lung disease, and then I is IV drug abusers. So in these situations, that is in the context of Pepsi, you have to use antibiotics which can cover Staphylococcus aureus. Now, when do we suspect Pseudomonas infection? So I have given the mnemonic SIN. One is structural lung disease, I is immunosuppression, and N is neutropenic patients. So to suspect Staph aureus infection, you have the mnemonic Pepsi, and to suspect Pseudomonas infection, you have the mnemonic SIN. Now, when do you suspect anaerobic infection? I call this as CAD. The mnemonic is CAD. C is CVA. In cerebrovascular accident, there is aspiration. So patient is unconscious, so he tends to aspirate. In such situations, you have to think of anaerobic infections. And alcoholism, if the patient is a chronic alcoholic, in such patients also you must think of anaerobic infections. And now D is decreased consciousness. So patient who has decreased consciousness tends to aspirate, and whatever commensal anaerobic organisms are present in the mouth and the upper respiratory tract, they get into the lung and cause anaerobic infections. So in Staphylococcus aureus, you have the mnemonic Pepsi, and for Pseudomonas infection, you have the mnemonic SIN, and to suspect anaerobic infections, you have the mnemonic CAD. So, based on these risk factors, apart from the beta-lactam antibiotics, whatever we discussed just now, so Staphylococcus aureus, you'll have to start the patient on gram-positive cover. And Pseudomonas, of course, piperacillin tazobactam will be helpful, or cefepime may be helpful, or ceftazidime may be helpful. So empirically, you may have to choose one of these antibiotics based again on the severity of the infection. And for anaerobic infections of the respiratory tract, we normally use clindamycin. So that will cover the anaerobes causing infections of the respiratory tract. Now we have a cascading story game. Here, this story is devised to bring an awareness on what antibiotics do not work in the respiratory system or respiratory tract, and also what antibiotics should not be used in pregnancy. So for this, I have a story. Tabassum, a primigravida, having a baby with cephalopelvic disproportion. So this Tabassum T having baby with CPD. In the 36th week of pregnancy, she is admitted to the hospital to plan for an elective cesarean section. Now what happens is she develops hospital-acquired pneumonia after about 3 days. Now what antibiotics have to be avoided in hospital-acquired pneumonia? So here she has acquired hospital-acquired pneumonia, and what antibiotics have to be avoided? Actually, this T and CPD, they represent the mnemonics or the first letter of the antibiotics that need to be avoided in hospital-acquired pneumonia. So T is tigecycline, which is one of the reserved antibiotic. Very irrationally, this is being used for respiratory infections, skin soft tissue infections, intra-abdominal infections, CNS infections, urinary tract infections, thinking that tigecycline is a reserved, very broad spectrum antibiotic which can kill any organism. So remember, if it is a hospital acquired pneumonia, you need to avoid using tigecycline because it doesn't reach a good concentration of in the lung. Then CPD, C refers to cholestyramine. Again, the same reason why you can't use cholestyramine. And then P is polymyxin B. Again, this doesn't achieve a good concentration in the lung. And D is daptomycin. Daptomycin is not used because it is inactivated by the lung surfactant. This daptomycin is an antibiotic used against gram-positive organisms, but because it is inactivated by the lung surfactant, you can't use daptomycin. So, tabasum with CPD. TCPD is the mnemonic for remembering what antibiotics need to be avoided in hospital-acquired pneumonia. Now, let us try to understand what antibiotics need to be avoided in pregnancy. See, here is a mother, and the clue for this question lies in the diagram of the fetus. Here is the fetus diagram in utero depicted. The clue is to identify the letters COT, an inverted FQ, and letter DO in the diagram. So how do we identify this? Let us see. This is C, this is O, this is T. So COT represents cotrimoxazole. So cotrimoxazole cannot be used during pregnancy. Now we have DO represented on the ear, a big D and a small O. So that is doxycycline. So doxycycline cannot be used during pregnancy. Now this is inverted F and inverted Q. FQ represents fluoroquinolones. So these are the three antibiotics which need to be avoided during pregnancy: cotrimoxazole, fluoroquinolones, and doxycycline. So this particular cascading story game helps you to remember what antibiotics cannot be used in hospital-acquired respiratory tract infection, especially lower respiratory tract infection, and what antibiotics need to be avoided during pregnancy. Now, we have another puzzle. This is called the star puzzle. The patient is pregnant and has hospital-acquired pneumonia. It's just similar to Tabasum having a CPD child. Now, there is a clue in the story that I have given, that is Tapasum with CPD, and the picture puzzle has the clue for antibiotics to be avoided in pregnancy. Now what I'll do is, I have represented a number of antibiotics in the next slide. Now based on this clue in the story and the picture puzzle, identify 6 antibiotics that cannot be used in the above clinical scenario. Arrange these antibiotics in the alphabetical order. Then number them serially from 1 to 6 and write these numbers at the corresponding antibiotic in the diagram. In the next diagram, I have given you a host of antibiotics. So in that, what you need to do is, you have to arrange all these antibiotics that have to be avoided in pregnancy and also in lower respiratory tract infection, and then give them the numbers 1 to 6 after arranging them alphabetically. Then what you need to do is join number 1 to 2, 2 to 3 and 3 to 1. Then join 4 to 5, 5 to 6 and 6 to 4 in the below diagram. The goal is to get a star by joining these numbers correctly. If you have identified these antibiotics correctly and if you have then arranged them in alphabetical order and given them the numbers, serial numbers, and then joining these dots, let us see what they are. See, here I had showed you a host of antibiotics, and the antibiotics that have to be avoided in lower respiratory tract infection and pregnancy is given like this. colistin or polymyxin B, then you have cotrimoxazole, then daptomycin, doxycycline, levofloxacin or moxifloxacin, and tigecycline. See, in the host of antibiotics provided in the previous diagram, you pick up these antibiotics which cannot be used in lower respiratory infection, especially hospital acquired and during pregnancy. So we have arranged them in the alphabetical order. So there you give the serial number 1, 2, 3, 4, 5 and 6. So then what you need to do, let us see. So you have given this now antibiotic colistin polymyxin number 1. Then cotrimoxazole is number 2. Then number 3 is daptomycin. Number 4 is doxycycline. Then number 5 is levofloxacin or moxifloxacin. Then number 6 is tigecycline. Now let us see how to join. So 1 to 2, then 2 to 3, then 3 to 1. Next, we have 4 to 5, 5 to 6, 6 to 4. So here you have a star formed. So if you identify the antibiotics that cannot be used in the lower respiratory tract infection and pregnancy, you will get this puzzle rightly. That is, the final aim is to get a star like this. So this is called the star puzzle. Now we have the carom game. This game is devised to make you understand the pharmacokinetics and pharmacodynamics of some of the antibiotics. Now here in the next slide I have shown a carom board and the 4 pouches are labeled that capital A, B, C and D. The striker is given in or shown in green color. The answer options A, B, C, D are shown in black. What are these answer options? I will have a question for you, just like the MCQs. So for MCQs, you will have the option A or B or C or D. So these A, B, C, D are shown in black on the carom board. I'll show you the diagram again. Then numbers 1, 2, 3, 4, 5, 6, 7 and 8. They represent the red ring on the carom board where you are supposed to keep the striker. That position is designated by 1, 2, 3, 4, 5, 6, 7 and 8. Now let us see. See the 4 pouches, the capital A, B, C and D. Then the options, that A, B, C, D options for multiple choice questions are represented in black here. A, B, C and D. The striker is represented in green here. It is at position 5. But you can keep the striker at any position like 1, 2, 3, 4, 5, 6, 7 and 8. Now what I'll be doing is, I'll give you a question and you have to identify the right answer. The options will be either that small letter A, B, C or D. Now in this situation, so here a multiple choice question is displayed with options as A, B, C and D. For finding the correct option, a clue is given. For example, for a question, the clue may be if the striker is kept at position 5 and pawn X may be A, B, C or D. If pawn X has to be pushed into pouch B, the path travelled by the striker and pawn X will be a straight line. So here, remember, the position of the striker is at 5. Pawn X has to be pushed into pouch B. So the path taken is a straight line. Let us see what that path is. See, 5 is here and it has to be the option maybe A, B, C or D, which is represented as X. Now you have to push that into pouch B. So we're using the striker. You have to push the option either A, B, C or D into B, and the path traveled by the striker and the pawn going into pouch B will be a straight line. So if that is to be done, what should be the answer? Obviously, it is B. So if you have to keep the striker in position 5 and push the options A, B, C or D into B, and if the path has to be a straight line, obviously the answer is B. So that's how the clue is given. Now let us see. So striker is kept at position 5 and that hits pawn X. The angle formed by joining the point of the striker to pawn X and the line travelled by the pawn X to enter pouch A is an obtuse angle. So now striker is kept at position 5. There is a pawn X, that means either A, B, C or D. That's the option. So the angle formed by joining the point of the striker to the pawn X and the line travelled by pawn X to enter pouch A is an obtuse angle. So the answer is obviously A. I have just given you the clue so that you will find the answer. D also could be an option, but usually if pawn is to be sent to pouch A, the striker will be in position 6. Let me explain to you here. So you have kept the pawn, and then the striker is at position 5 and the pawn has to be sent to this pouch A. So the angle formed by the striker hitting the pawn and the pawn entering into the pouch is an obtuse angle. So it can't be this. Of course, you won't be hitting this. I mean, if this is the option, you'll have to hit here. So it won't be, it's not a right position to send this. This is not the way you play. Could this be this one? Normally, you don't keep the striker at position 5 to hit this D to A. So, would obviously keep it at position 6. So, and this cannot be sent to pouch A from here. So, obviously, it has to be A. Let me show you. So, this is the line joining the striker, that is a path traveled by the striker to hit the pawn A, and then the pawn traveling the distance from that position A to pouch A. So this angle is an obtuse angle. So like this the clue is given. So the answer is A. So these are something like multiple choice questions, and to find the correct answer the clue is given. So as puzzles the clue is given, and if you solve that puzzle you will be able to get the right answer. Now let me take you through these questions. Which of the following drugs can be used in hospital acquired lower respiratory tract infection? So here options are A. Tigecycline, B. Piperacillin tazobactam, C is daptomycin, D is colistin. Now the clue is keeping the striker at position 4, the pawn X is sent to pouch B will be a straight line or little less than 180 degree. That is the clue. So what is X? So keeping the position at striker, keeping the striker at position 4, pawn X, let me take you here. So you keep at position 4, the pawn has to be sent to pouch B. So the line traveled is almost a straight line or little less than a straight line. So if you keep it here and send this pawn A to B, it won't be a straight line or a big obtuse angle. Or if you want to send this D to this B, it will be an acute angle. And if you want to send C to B, it won't be possible. So the only option is B. So let us see. So this is how it is. So it's almost a straight line or little less than a straight line or less than 180 degree. angle. So obviously the option is B. So B is piperacillin tazobactam. The other options are not correct. The reason for which I have already given. Now the next question is, in which of the following infections can tigecycline be used? So this is again to understand the pharmacokinetics and pharmacodynamics. Can it be used in UTI? Can it be used in bloodstream infection? Can it be used in respiratory infection? Can it be used in skin soft tissue infection? So these are the options A, B, C, D. You have to find the answer, for which the clue is given like this. Keeping the striker at position 3, when pawn X is sent to pouch D, it is an obtuse angle. What is X? So let us see the diagram. Position C, and you have to send the pawn to D. So it will be an obtuse angle. So what is the option? Can you drive this A to this D? It is difficult. So you don't keep like this. You would rather push it into pouch A. Now, if you want to push this one, D, see, if you hit it here like this and come, no, sorry, if you hit it here and then at this point it can be pushed to D. So it's an obtuse angle. But can you hit C to D? That may also be an obtuse angle, but normally nobody chooses to keep the striker here. They would rather try to keep the striker at 4 and drive it to pouch D. So what is the answer? Let us see. So you hit it there and from at the edge of this pawn at this position, and then it is pushed to D. So this is an obtuse angle. So obviously the answer is D. So that is skin and soft tissue infection. In other infections like respiratory tract infection, I already told you can't use tigecycline. Bloodstream infection also you can't use tigecycline, and urinary tract infection also you can't use tigecycline. So the only option, only place where you can use tigecycline is skin and soft tissue in the options available. The other option is the intra-abdominal infections caused by multi-drug resistant organisms. There also you may use tigecycline. Now the next puzzle. What is the dosage of piperacillin tazobactam for severe lower respiratory tract infection caused by multi-drug resistant bacteria? So the options are A, 4.5 grams 6th hourly infused over 30 minutes, 4.5 grams 8th hourly infused over 30 minutes, 4.5 grams 6th hourly infused over 4 hours. Number D, 4.5 grams 12th hourly infused over 1 hour. So what is the option? The clue given here is keeping the striker at position 1 and push pawn X to pouch B. If you do that, the angle will be acute angle. Let us see what it is. So you keep the position of the striker at 1 and you have to push the pawn to B. So the angle formed between the striker and the pawn that is hit, and then the pawn to the pouch is an acute angle. So let us see. See, can you hit it like this? D to B, it is not possible. Then from here to C, if you hit, of course you can hit and it will go here. Can you hit B? You have to hit here, it is difficult, and to send it to B. And then this obviously will be an obtuse angle or almost a straight line. So the option is only C. So you hit it and then this will go back, rebound and go to pouch B. So the answer is C. That is 4.5 grams given 6th hourly and infused over a period of 4 hours. So in severe infection, the dosage of piperacillin tazobactam is 4.5 grams given 6th hourly and the infusion duration is 4 hours. So that is the correct answer. Next one. Now, why is daptomycin not effective in lower respiratory tract infection? You have various options. It's inactivated by the surfactant, does not reach sufficient concentration in the lung, it's highly protein bound. Number D, it is metabolized in the liver. So the clue is keeping the striker at position 8, pawn X is sent to pouch B, then it is a straight line. So let us see what is X. So 8, you have to keep the position of the striker. Then this thing has to be sent to B, obviously. So this thing is a straight line. The path is a straight line. Obviously, the answer is A. That is, daptomycin is inactivated by the lung surfactant. That is why you cannot use daptomycin in lower respiratory tract infections. Okay, that's the answer. The next question is, which of the following organisms is intrinsically resistant to colistin? So, of these organisms, which one is intrinsically resistant to colistin? Number 1 is Proteus mirabilis, 2 Klebsiella, C. E. coli, D. Pseudomonas. Now the clue is keeping the striker at position 5 and sending the pawn to X. Pawn X to pouch D is an acute angle. So what is X? So the position of the striker is 5 and you have to send the pawn to D. So what is X? Let us see. See here, you have kept the striker and you have to send the pawn to D. So it should be an acute angle. So obviously it is A. So A is the answer, that is Proteus mirabilis, or all species of Proteus are intrinsically resistant to colistin. Thank you friends for watching this video. Please like, share and subscribe to my YouTube channel.